Hi friends, welcome to this another important topic for your upcoming exams, and that is shock. So what actually is shock? So shock is a state of basically circulatory failure. So shock is basically a state of circulatory failure that is characterized by decreased oxygen supply to tissues. That is characterized by decreased oxygen supply to tissues, and that results in the tissue hypoxia as well as the hypoxia at cellular level. So you have the tissue hypoxia and you have the cellular hypoxia, and it's a very important condition. It's a very important condition that you encounter in critical care settings. It's a very important condition that you encounter in critical care settings, and ultimately if not recognized, the shock, if it's not recognized properly, it can give rise to mortality. It can give rise to mortality, right? So from the shock, what you have to remember is what are the different types of shock and what are the hemodynamic alterations that you see in the patients of shock, right? So what you have to remember is shock in initial stages is reversible. Shock in initial stages, it's reversible condition. But if it is not recognized, then it becomes irreversible. And ultimately the end fate of all the shocks is basically death from the multi-system organ dysfunction. So the shock initially, if you do not recognize it, then it becomes an irreversible shock, and irreversible shock ultimately turns into a multi-system organ failure. Previously this term was known as MODS, multi-organ dysfunction syndrome, but now the terminologies they are using is a multi-system organ failure or organ dysfunction. So you have MSOF, that is the new terminology that's being used. Now what are the different types of shock that you encounter, right? So you have a hypovolemic shock, you have a hypovolemic shock, you have a distributive shock, you have a cardiogenic shock, you have a cardiogenic shock, and you have the obstructive shock. Now, what you have to remember is the most common type of shock overall is the hypovolemic shock. Now this is the most common type of shock overall, but most common type of shock in ICU setup. It is your septic shock. Right? And septic shock basically falls into the category of distributive shock. Right? Now, what are the things that are important whenever you are evaluating a patient of shock? Right? So first, foremost thing, we'll just write down the names. What are the things that are important? One is the systemic vascular resistance. Second is the cardiac output. Third is the central venous pressure. And fourth is the pulmonary capillary wedge pressure. So if you just go through this diagram, what you can see, there are two things. One is the afterload. Basically, afterload means the systemic vascular resistance. It's basically the systemic vascular resistance or the blood pressure that is being offered by the blood vessels, right? It is the systemic vascular resistance, and systemic vascular resistance is kind of synonymous with the afterload. We have the preload The preload means the end diastolic volume. The preload means the end diastolic volume. From here the heart pumps the blood and it encounters the systemic vascular resistance, and ultimately from here the blood goes into the system, and that is known as the cardiac output. This is basically what you have read in your physiology lectures. Now what we have to know is, when we are dealing with a patient of distributive shock, so what are the causes of distributive shock? We have mostly the most common cause of distributive shock is septic shock. Now there are other things that we can encounter in distributive shock, that is due to pancreatitis, severe burns, where you have the third spacing or third space loss. So due to the third space loss, you basically develop hypotension and shock. Other causes: anaphylactic, neurogenic shock, adrenal crisis. So what is happening in distributive shock is that your blood vessels, they dilate. So there is vasodilatation. As a result of vasodilatation, the systemic vascular resistance decreases. So systemic vascular resistance is decreasing in septic shock or the distributive shock. What is happening is there is increase in cardiac output. So if the blood is being pumped from here, the little amount of blood will accumulate in the heart, and ultimately this blood which accumulates, you have the pulmonary veins here. Which is basically responsible for the pulmonary capillary wedge pressure and the central venous pressure. So if the blood accumulates in the heart, from the left ventricle it will go to the left atrium, and ultimately it will go into the pulmonary circulation by backflow hypothesis. This is the basic physiology concept you know. So if in the I'm telling in the distributive shock or in the septic shock, the blood is being pushed forward, there is increase in cardiac output. There is a paradoxical increase in the cardiac output, and that's why you'd have decrease in the pulmonary capillary wedge pressure. And you have decrease in the central venous pressure. Right now, if I talk about the hypovolemic shock, what you are getting is there is a vasoconstriction. Right? There is a vasoconstriction, in that there will be increase in the systemic vascular resistance, but there would be decrease in cardiac output, there would be decrease in pulmonary capillary wedge pressure, and there would be decrease in the central venous pressure. So as I already mentioned, that hypovolemic shock is the most common type of shock. So any sort of fluid loss, hemorrhage will ultimately contribute to hypovolemic shock. So you have hemorrhage, whether it's due to the trauma or due to the GI bleeding or due to the ruptured ectopic pregnancy, whether you have a GI loss, you have a burns, you have a polyuria, you have a DKA, or you have a diabetes insipidus, all this will constitute the hypovolemic shock. Now when you are dealing with the cardiogenic shock, what is happening in cardiogenic shock? There is increase in systemic vascular resistance due to the vasoconstriction, but there is a pump failure. So there is a decline in cardiac output, and there is a backward flow of blood into the system. So you would have increase in pulmonary capillary wedge pressure, and you would have increase in the central venous pressure. So what you are getting is cardiogenic shock causes would be myocardial infarction, myocarditis, certain type of arrhythmias, certain cases of valvular stenosis like aortic valve insufficiency and mitral valve insufficiency. So this is about the cardiogenic shock. But when we come to the obstructive shock, what you are getting is, again, there would be an increase in the systemic vascular resistance due to vasoconstriction. And what you are getting is there is a decline in cardiac output, Again, there would be an increase in pulmonary capillary wedge pressure, and there would be increase in the central venous pressure. So this is about the obstructive shock. So this I have explained you the different things that you can encounter in a patient of shock. So what is to be remembered is that all types of shock, if I give you a summary, so the summary is basically all types of shock, they have decreased cardiac output, except distributive shock. Another thing I would like to write, all types of shock, they show increased systemic vascular resistance. Again, the exception is distributive shock. Right? So now we'll just read about the different things, the different formulas that you need to know for your shock classification, for your physiology that is related to the shock. So what we just discussed is that there is a tissue level hypoxia. In a patient of shock. So what is actually happening is there is a decline in the arterial oxygen delivery. This arterial oxygen delivery is basically dependent on the cardiac output and on the arterial oxygen content. Okay, but the cardiac output is basically dependent on the heart rate and the stroke volume. More the stroke volume, more will be the cardiac output. More the heart rate, more will be the cardiac output, right? And the stroke volume is basically dependent on the preload and contractility divided by the systemic vascular resistance. So if you have a vasoconstriction, or if you have an increase in the systemic vascular resistance, concomitantly there will be the decline in stroke volume. So now, having read all that, this is just a summary of what I just discussed. Now this is a very important slide for your exam point of view. If you are clear with the concepts that I have just taught you, you will be able to answer all the questions that are being asked related to shock. So if I just told you that in distributive shock, that is the septic shock, what you get is vasodilatation. So as a result of that, there is decline in systemic vascular resistance. So all the types of shock, they show increase in systemic vascular resistance except distributive shock. All the types of shock, they have decrease in cardiac output except distributive shock. And in the cardiogenic and in the obstructive shock, you're going to have increase in the central venous pressure and in the pulmonary capillary wedge pressure. So this is all in all about the shock. This is a very important slide for your exam point of view, the hematological alterations that you're gonna get, the blood parameters that you're gonna get for your exam point of view, the hemodynamic alterations. So this is a very important concepts for your exam, and if you have to read anything from the shock for your exam point of view, this has to be this particular slide. I hope you guys have liked this lecture. Thank you.